Once upon a time, in a NICU many years ago, there was a 23-weeker who was on NIPPV. The baby's respiratory status worsened overnight, so the nurse practitioner intubated and placed the baby on a high-frequency oscillator. This was the X-ray taken soon after the baby was transitioned to the oscillator. And I want you to look at it carefully. This X-ray was taken around 1 in the morning. Around 7 a.m., the neonatologist who was on clinical service was in his office looking up the X-rays from the previous night. He had not been told that the baby had been intubated and put on the oscillator. He called to the unit and said, I want you to get a cross-table lateral and repeat the AP view. And this was the portable cross-table lateral. The neonatologist had noticed that on the original film, there was a thin layer of air under the right diaphragm, which had been missed the previous night. This is a picture of another baby that I took care of. What do you see on this X-ray? Obviously, you see the pneumothorax, the chest tubes, the central venous line. But it wasn't till much later, when the baby had recovered, that we noticed that the left humerus had a fracture. And all of us had missed it, including the radiologist. So these are examples of diagnostic errors. And in this conference, for the last 3 days, we have heard repeatedly about diagnostic errors. You might not have recognized them. When Ryan McAdams talked about his experience with patients, there was a baby who had not received vitamin K and was bleeding, and nobody knew that until he went and investigated. That baby had been admitted for a pneumonia, but turned out to have HSV infection with hepatomegaly. When Dr. Janvier talked about parental preferences, to me, that's a misdiagnosis. It's a misdiagnosis of what parents want to hear about. And if you came to the story hour where our neonatology colleagues shared their stories and reflections about their experiences, you heard that even death can be misdiagnosed. So this is a common problem, and there are data to establish this. A diagnostic error is defined as the failure to establish an accurate and timely explanation of the patient's health problems or communicate that explanation to the patient. A recent study in adult patients showed that every year about 800,000 adults either die or are left with permanent disability in the US from diagnostic errors. If you look at data from the PICU, the frequency of diagnostic errors has been reported to be anywhere from 1.5 to 12%. We have done studies in neonatology. My former fellow, Grant Schaefer, who's now a neonatologist in Chalk in California, I mentored him in this project, and we found that at Texas Children's Hospital, there were 6.2% frequency of diagnostic errors out of 600 neonatal charts reviewed. And Grant has gone on to write several other papers. We've written 5 papers on this topic together. And most recently, he has done work showing that people are not doing a red reflex exam on babies before discharge. And in his review, only 66% of babies had a red reflex exam documented in the chart before discharge. And he did a quality improvement project, and it increased to 95% in his unit right now. If you look at lawsuits, diagnostic errors are the most common category of lawsuits in healthcare, not just in neonatology, but in healthcare. This problem is so serious that the Institute of Medicine, now known as the National Academy of Medical Sciences, published a report in 2015 called Improving Diagnosis in Healthcare. And just a few days ago, on September 17th, the CDC announced a focus on diagnostic excellence, and they published on their website the core elements of diagnostic excellence. The World Health Organization on the same day announced a focus on improving diagnosis for patient safety, and their slogan was, "Get it right, make it safe." In 2004, I published one of the early papers on medical errors in neonatal intensive care. This was because the Institute of Medicine had published a 1999 report saying that every year, 44,000 to 98,000 Americans are killed every year in the US from medical errors. But in that report, there was hardly any mention of diagnostic errors. And in my paper, only 7% of the more than 1,200 errors reported were diagnostic errors. So even though patient safety has been a recognized problem in the US healthcare system, diagnostic errors have not received the respect they deserve until now. So we need to address this problem. Why do diagnostic errors occur? All of you know the sequence of how physicians make a diagnosis. We get a history, or we're supposed to. We do a physical examination, or we're supposed to. We're supposed to generate a differential diagnosis and come up with a diagnostic strategy. We're supposed to do that. And then we order the lab tests, the imaging tests, and the consults, come up with a provisional diagnosis. And as the patient's course evolves, we make diagnostic revisions. And we're supposed to get feedback about our diagnosis. Was it accurate? Was it partially accurate? Or completely inaccurate? This doesn't happen as it should. A lot of times, if you go to morning report, you will hear people saying, "This patient presented with seizures, so I got an MRI and ordered a neurology consult." There's no mention of the physical exam or the differential diagnosis. They just tell you what they did. Yazdani and colleagues from Iran have published a model of how physicians and clinicians arrive at a diagnosis. Now we're entering the field of cognitive psychology. I'm not a cognitive psychologist, but I play one on TV. So Yazdani and colleagues say that how the physician arrives at a diagnosis is like the two sides of a zipper closing. On the one side are the knowledge structures that we gain during our training by our reading, and we learn about the diseases, their presentations, the probability of symptoms and signs with each condition. And on the other side, as the patient's history and physical exam and other information is gathered, the problem representation also evolves. So these two things, the knowledge in our head and the evolution of the problem representation, come together just like a zipper closing until you reach the provisional diagnosis. What's the diagnosis in these following patients? You can call it out. A 1-week-old term infant after total body cooling, you turn the baby over, subcutaneous fat necrosis. What does this patient have? Yeah. What does this patient have? Brilliant. So if you notice how you did that, there was not even a second before you made the diagnosis and responded with your answers. It was milliseconds. Arthur Conan Doyle, the author of the Sherlock Holmes series, modeled Sherlock Holmes after one of his professors, a surgeon called Sir Dr. Joseph Bell. And Dr. Bell was renowned for his diagnostic excellence. So he would sit in his clinic, and as the patient came in, he would be able to look at the patient and tell the students, "This patient has come from this island. She came by ferry. She has 2 children. She left one child at home, and she's brought the other one with her, and she has this diagnosis." And if you listen to a TED talk by Abraham Verghese, it describes how Dr. Bell makes these diagnoses and how brilliant he was as a diagnostician. When Arthur Conan Doyle, who was an ophthalmologist, started writing his short stories and novels about Sherlock Holmes, he modeled the detective after his professor. Because diagnosis is like deduction. Just like my colleague who spotted the air under the diaphragm, that was a brilliant piece of deduction, just like Sherlock Holmes. Now, what you did when you looked at those images and made a diagnosis in a second was what Dr. Bell used to do. He used to look at a patient and make a diagnosis instantly. Now I want you to look at this patient and tell me what you think this patient has. Silence. Nobody is yelling out a diagnosis. And I would say don't even bother, because you could stare at this image for 1,000 years. I could have stared for 1,000 years but not made the diagnosis. This is a condition called Okamoto syndrome. There are only 6 cases reported in the world when I last checked. So you cannot make a spot diagnosis in this patient like you did in the other images. What's the difference between how you yelled out a diagnosis for those other images and this one? The answer lies in cognitive psychology again. Psychologists for many years have talked about the dual processing system of how the human brain works. And this was popularized by Daniel Kahneman in his book, Thinking Fast and Slow. And these experts say that there are 2 systems in our mind. One is called System 1, which is very fast. It's based on heuristics or rules of thumb. We're not aware that we're doing that. The cognitive awareness is low. It's automatic. The effort involved is very low. But we tend to make errors that have a normative distribution. System 2 is the analytic system that you tried to use when I showed you the Okamoto syndrome image. It is more analytic, it is slow, it is methodical, and it takes high cognitive effort. We tend to favor System 1 thinking as humans because we are what is known as cognitive misers. We want to expend as little cognitive energy as possible when making decisions or making diagnoses. So System 1 is the most convenient. And as we become more experienced with medicine and we become seasoned clinicians, we tend to use System 1 more and more, just like Dr. Bell, except once in a way, we make a mistake. Because we look at an X-ray and say, yeah, that's RDS, and the tube is in the right place, and we miss the air under the diaphragm because we're in System 1. We don't look at it. When you're in System 1, there are many cognitive processes that lead to error. One is called availability bias. So a diagnosis that is easily available to you because you've seen so much of it lately, like during COVID, every patient we encountered had COVID potentially. I once had a child who was a preterm infant with ground glass opacification of the lungs, had severe respiratory distress. We thought it's RDS because that was the diagnosis most available to us. That baby died. The autopsy revealed total anomalous pulmonary venous drainage with obstruction. And we had not even considered that. Confirmation bias is when you make a diagnosis and everything you do after that is to identify facts which confirm your diagnosis, and you don't look for things which refute your diagnosis. Premature closure is arriving at a diagnosis very quickly and saying, case closed, the baby has passed meconium, so his anus is normal. And you miss a low anorectal malformation, such as a perineal fistula or a covered anus or even anal stenosis. This has been reported many times. The mother's RPR is negative, so there's no possibility the baby has congenital syphilis, and you ignore the fact that sometimes mothers seroconvert late, and even though the RPR is negative, the baby could be at risk. Base rate neglect is when you ignore the background frequency of the disease and chase down exotic, exciting diagnoses. Framing effect is how the information is presented affects your interpretation of the data and what diagnosis you made. If you get a baby on transport and the referring doctor says, I have a baby with HIE, that's it. That's the frame within which you work, and you forget to think about perinatal arterial ischemic stroke or a cerebral sinus venous thrombosis or any other cause of neonatal encephalopathy. So when you're in System 1, and especially if you're busy and acting fast and you're in a busy NICU and there's not much time, you're efficient, but your brain is tending to all these biases. In fact, if you look at the literature in psychology, There's more than 100 cognitive biases described. What do you see in this picture? So it's like a Rorschach test. Maybe you recognize something, maybe you don't. But if I show you this, that there's an outline of a cow head or a calf head, and then when I show you this picture again, do you see it? That's called pattern recognition. So once you see it, once I show it to you, and you go back to this, you'll always see the head of the cow. That is how our brains are trained to recognize patterns. What do you see here? This was a PICU patient, and obviously you see the scoliosis, the crowded ribs. But if you look carefully at where the right mainstem bronchus is descending, there is an opacity. That was an inhaled tooth. That was completely missed by the clinicians and the radiologists. Because what happens here is you see the scoliosis, the crowding ribs, and you close out the case, premature closure, sometimes also known as search satisficing, and you stop looking and saying, yeah, I found the pathology. Another reason why we make mistakes with diagnosis is overconfidence. Clinicians are overly confident, and they've done studies where you give them case vignettes. The degree of their confidence in accuracy of diagnosis has nothing to do with the accuracy of diagnosis. There is a systematic review about how to prevent diagnostic errors, 26 studies. They list things like communication methods, audit processes, additional patient reviews, computerized decision support, checklists, and educational programs. Unfortunately, there is limited evidence of efficacy. So any recommendations we have today about preventing diagnostic errors are speculative and hypothetical. They're not high certainty evidence. So what can Sherlock Holmes teach us about preventing diagnostic errors? If you read Sherlock Holmes, and I was a big fan when I was growing up, the first thing he does when he solves a case is a very good information gathering. He goes to the site, he inspects the site, he talks to the witnesses, and he explains to Watson, you know my method. It is founded on the observation of trifles. And he tells Watson, because he sees things that Watson doesn't, and he tells Watson, you see, but you do not observe. And I think we should tell each other this in medicine. We see, but we do not observe. In a morning report once, our fellow presented this X-ray to us and said, asked us, what do you see? And I didn't see anything. I thought maybe there's some density behind the heart. And then the fellow told us, this baby who was 2 weeks old has severe combined immune deficiency syndrome detected on a newborn screen and had presented with epistaxis. What was not seen on this X-ray is a thymic shadow. There is a story by Conan Doyle where Sherlock Holmes goes to investigate the theft of a horse called Silver Blaze. And he tells the Scotland Yard detective, there is something curious about what the dog did last night. And the detective asks him, but the dog didn't do anything last night. And Sherlock Holmes says, that's what I'm talking about. It's curious that the dog did not bark when the horse was being stolen, which means that the person who stole the horse was somebody the dog was familiar with. So this is known as the curious incident of the dog at nighttime. So paying attention to what is not there and what has not happened is also part of observation. Sherlock Holmes also does careful, meticulous analysis, and he explains, now, I make a point of never having any prejudices and of following docilely wherever fact may lead me. And he also says, this is one of my favorite quotes, it is a capital mistake to theorize before one has data. Insensibly, one begins to twist facts to suit theories instead of theories to suit facts. Essentially, he's guarding against premature closure. He says, get the information before you start making the diagnosis. He also uses what the psychologists say are called cognitive forcing strategies or debiasing or diagnostic timeout. And he reminds himself, one should always look for a possible alternative and provide against it. It is the first rule of criminal investigation. And he also says, there is nothing more deceptive than an obvious fact. So he knows that his mind may go into system one and be prone to biases. So he reminds himself, okay, check yourself. Another technique that the psychologists have proposed to reduce diagnostic errors is metacognition, which is thinking about thinking, and also mindfulness, which is being in the present moment, taking a break, and calming your mind. And Sherlock Holmes, in his novel, A Study in Scarlet, says, let me see, what are my other shortcomings? So he's aware that he has some shortcomings in his thinking. And once Watson is pestering him, asking him, tell me what you think about this, who do you think committed the crime? And he says, it is quite a three-pipe problem, and I beg you won't speak to me for 50 minutes. Leave me alone, I need to think about it. So once in a way, if you have a complex case that is not obvious, you need to go away, sit down, get quiet, think about it. Holmes is also good at articulating his thought processes. He explains to Watson why he's thinking what he's thinking, why he's making a diagnosis. And he kind of walks through his thinking. And he says, nothing clears up a case so much as stating it to another person. So team diagnosis, where I'm on rounds and I make a diagnosis, but then somebody else cross-checks me and asks me, can you explain why you think this baby has X, Y, or Z? That is one potential way to prevent diagnosis. And he says in The Hound of the Baskervilles, it is a scientific use of the imagination, but we always have some material basis on which to start our speculation. So he can explain why he's thinking what he's thinking. That means he's aware of his thinking, which a lot of us are not, because we're mostly unconscious thinkers. So we started this conference, DELPHI conference, with a great talk by Dr. McAdams on artificial intelligence. And my call to action to all of you is, let's use real intelligence. Thank you for your attention. These are my conclusions. Take care.